Okay, so like to welcome everybody. Thank you for taking your time. I know everybody's schedule is busy, so we're doing a lunch and learn here, and we're trying to fit in different time zones. And if you're working in a school, you might have the intention to be here all the time, but something might happen, and we understand that. So again, we're thankful that you're here. My name is Patrick Lowen. I am the Senior Special Education Support Technician at Chiefs of Ontario, and we are super excited to have Layla Hall with us here from Surrey Place. So I'm going to let Layla introduce herself because she obviously knows herself better than I do. So yeah, the floor is yours, Layla.
Okay, thank you. Can you hear me okay? Yes?
Yep.
Awesome. Hi, everybody. And I want to say thank you also to the Chiefs of Ontario for inviting me to present today. I'm really quite honored to be here to talk with you about developmental disabilities through an Indigenous lens. I am a psychologist by training, and I completed my doctorate at Queen's University with a focus in autism and developmental disabilities across the lifespan. And so I've worked for a handful of years now at Surrey Place, which is an agency in Toronto providing clinical services to people with autism and developmental disability. My role is in the adult program, providing services to adults with disability in Toronto, and also with our mobile clinical team, which provides clinical services to children and youth in Indigenous communities across Northwestern Ontario, both through telehealth and through travel. So before we start, I just would like to acknowledge my position of privilege as a white clinician with Italian and British heritage. I'm trained as a psychologist with a specialization in disability, but my learning journey is ongoing, and especially with respect to the experiences of Indigenous peoples. So I recognize and I'm grateful for the Indigenous teachers who've helped me along my path to build a more culturally competent knowledge. I'm always learning, and I'm humbling myself today as I present to you all. My hope is that we'll learn together and from each other. And I'd also like to just acknowledge not only the land that I'm on here in Toronto, which is traditional territory of many diverse nations, but also the lands and nations and territories that are represented by all of you in attending. So I thank you all for attending, and I pay respect to all of your territories and communities. All right, so let's get into it. We're going to talk a little bit about terminology and then Indigenous perspectives of disability and how there can be some differences between Indigenous and Westernized approaches. We'll talk about 3 specific diagnoses that are often associated with developmental disability, so intellectual disability, autism, and fetal alcohol spectrum disorder. I'll also kind of quickly point you in the direction of some other neurodevelopmental disorders that we just don't have time to talk about today. We could be here all day, and I know you're all busy. And then I'll leave you at the end with some comments about supports and interventions and also some resources. So today really is just going to be a little glimpse into the world of disability, hopefully to give you a little bit of education, some things maybe you didn't know before, some things that might be repetition, and hopefully it kind of stimulates your interest in learning more going forward. Ooh, back. So just a bit about terminology. So developmental disability is it's a general term, and it really refers to a group of conditions that are lifelong. So they start in the developmental period before age 18. And they continue throughout a person's life, and they're conditions that impact someone's cognitive abilities and their adaptive functioning. So when I say cognitive abilities, I mean things like verbal skills, visual skills, memory, problem solving, knowledge recall, how quickly you're able to complete tasks, all sorts of skills. And the adaptive functioning is the part that refers to skills for everyday living and independence. So things like cooking, cleaning, getting around the community, budgeting, socializing, communication, all these things that we have to do in our lives. And so under the category of developmental disability, we often refer to different conditions such as intellectual disability, autism spectrum disorder, fetal alcohol spectrum disorder. Sometimes developmental disability and intellectual disability are used interchangeably. interchangeably, and often that's fine. But there are people who have developmental disabilities who don't have actual intellectual disability. They might have a number of strong cognitive skills in a number of areas and have a more variable profile. So we'll talk a little bit about that. Well, we might have someone, for example, who has autism, but who does not have an intellectual disability. And we would often still refer to them as having a developmental disability. I also just want to make a comment about global developmental delay, because this is something that comes up every now and then. And often, you know, people might present as teenagers or even adults who have this diagnosis. And in fact, it's really meant only to be a diagnosis that's given to children who are under 5 years of age. And we give that diagnosis when the child's not meeting developmental milestones across many areas. But because of their age and maybe because of other contextual factors or complexities, it's not possible to make a fair assessment of the full nature or severity of their challenges. So we can't really come up with an accurate diagnosis at that time. So we might give global developmental delay to identify that there's challenge, and it's kind of a marker until we can do follow-up assessment. And this is one that can be particularly important to recognize in Indigenous communities, where sometimes or often, almost always, there are inequities in access to healthcare services. And so somebody might be flagged at 5 years of age or under with this designation, and then they never get any follow-up because it is too hard to access the resources. And so when you see someone who has this diagnosis, it's a good marker that there should probably be some follow-up that should happen. So let's talk a little bit about Indigenous perspectives of disability. In traditional teachings, often individuals with disability have been referred to or viewed as people who have special gifts, who have a special connection to spirituality, or who have special and unique purposes that they can fulfill within the community. Often there is, ceremony, like such as naming ceremony, to help identify this individual's purpose and kind of give them the meaning within culture. So in Indigenous culture, often disability, at least historically, has been really embraced rather than segregated, which is kind of the history of Westernized culture. And unfortunately, because of colonization, there's been an impact of Westernized culture on Indigenous perspectives of disability as well. And I think it's really helpful for us in a healing process to revisit these kind of traditional ways of viewing disability from an Indigenous lens. There's lots of really wonderful language across Indigenous cultures in how people with disability are referred to. So in another training that I do, we call it a beautiful difference. And a beautiful difference comes from the Anishinaabe translation of disability, which is a beautiful difference. And I'm not going to attempt to pronounce that and completely make an embarrassment of myself and disrespect the language. Also, the Cree word for autism, instead of calling it autism, the word means she or he thinks differently. And I think this really emphasizes, again, this view of difference rather than deficit. So rather than suggesting that someone is got something wrong with them and should be segregated, it's about accepting differences and what that difference can bring to a community. Of course, we also can't talk about disability in an Indigenous context without acknowledging the role of colonization. And colonization's directly contributed to and continues to contribute to the Indigenous experience of disability in a number of different ways, both in terms of placing Indigenous peoples at increased risk of developing developmental disabilities, and also in terms of the supports and care that they're able to access when they do have these diagnoses. And there's, the history of being apprehensive of healthcare services and Westernized healthcare because of the way that we have really inappropriately treated Indigenous cultures, because of the lack of research and understanding about how disability should be viewed and treated and understood in Indigenous communities, but also in terms of the destruction of access to traditional practices, the destruction of traditional parenting practices, that would, allow for Indigenous parents to raise and rear their children in the ways that they see most fit to support the disability. So it's definitely apparent that there's conflict, between Westernized views and Indigenous views of disability. And this can become especially challenging with respect to diagnostic labels. And today we're going to spend a majority of the time discussing specific diagnoses. And really making diagnosis is a Westernized approach to disability. It does not necessarily fit with Indigenous perspectives and should not have to fit with Indigenous perspectives. Additionally, diagnostic terms are really rooted in Westernized perspectives and Westernized research, and they don't necessarily take into account developmental expectations from Indigenous cultural lenses. So clinicians, when they're working with Indigenous communities, need to be really well trained and have a strong understanding of the community that they're in and the traditions that are unique to those communities to ensure that they're appropriately applying diagnostic terms from that lens. Additionally, labeling can have the impact of stigmatizing or isolating an individual. And the challenge here is that because of policy, diagnosis is often required to access government-funded services and resources for people who have disability. So it becomes really important that we as service providers and clinicians are actively working on using diagnosis for helpful purposes, that diagnosis can and should be used to help identify the unique strengths and challenges a person is experiencing so that we can better understand how to harness their individual strengths and identify the supports they need to be included in their community and to achieve their goals. We also have to be careful to recognize that diagnoses identify needs at an individual level, but also disability is impacted by systems such as family, community, culture, colonization, which should also be targets of support and intervention. So understanding diagnosis is not all about changing the individual, but it's also about understanding the environment the individual is in, how that environment impacts their disability status, and how we can make changes to systems to better support the individual based on their needs. So it's really, I think, about taking a pragmatic approach to how diagnosis can be helpful. And if it's not going to be helpful in the community, then maybe it's not something that we do. Okay, so let's talk a little bit about specific diagnoses. We'll start with intellectual disability. So intellectual disability is a specific diagnosis that is really characterized by these three main traits: deficits in intellectual functioning, deficits in adaptive functioning, and the onset of these difficulties occurring during the developmental period, so before the age of 18. And when I talk about this intellectual functioning, again, this refers to the cognitive skills such as problem solving, planning, judgment, academics, learning, verbal skills, visual skills, memory. And when we think about someone with intellectual disability, while they will likely have certain strengths and weaknesses, their overall profile is going to be consistently lower than what we would expect of people their age. So how we assess this is we do standardized testing, and we compare how an individual performs on that test compared to the other people that would be their age, a general population that would be their age. And the idea is that if you were to line 100 people up who are the same age from number 1 to number 100, where number 1 is the person who's having the most challenge and number 100 is the person who is excelling the most. Number 1 and 2 are the people who would qualify for an intellectual disability. So that says that 90% of other people their age are performing more strongly than they are, and that they need some support to help them achieve their full potential, to help them achieve their goals, to help them build skills. So it's not about saying, well, oh, you're the bottom 2%, too bad for you. It's about saying, okay, the world must be really hard because you're 98% of people are kind of functioning at a level higher than you. So what can we do to help you to help you achieve your goals and to have meaning and achieve the things that you want in your life? And It's important to also note that when we do this testing, again, these tests are standardized on populations that are usually not representative of an Indigenous community. And again, this is why it's very important for when clinicians are doing this type of assessment to really understand how people within the community might on average perform, and to contextualize how a person performs within the context of the community that they are living, because that will inform what we do with the information and how we interpret the information. So then the other piece is that with intellectual functioning challenges come difficulties with everyday living. So there will be difficulties with cooking, cleaning, going out in the community, budgeting, based on the difficulties that a person has with thinking and reasoning. And often what we do is we'll identify kind of the level of severity or the level of impact that the intellectual disability is having on an individual. And we use IQ scores kind of as a general arbitrary cutoff of where a person falls. But really, when we're giving these severity criteria, we're thinking about how much support this person is required. So it's not about saying, oh, you're very severely impacted and we can't help you. It's about saying, if you're severely impacted, what supports, what does that mean about the level of support you need to achieve your goals and live a meaningful life? So when we think about these kind of severity criteria, we have people who are on the mild end, and this is the majority of people who have intellectual disability. And in the mild end, often people who have mild intellectual disability can be independent with a lot of practical skills like cleaning and bathing and feeding themselves, getting dressed. And they can also develop skills for work and for romantic relationships and for family. However, they are likely to require some support in certain kind of domains, especially when they're more conceptual in nature. So like with budgeting supports or with building job readiness skills, obtaining a job, they might need support there, childcare. And additionally, people in this kind of range might have more immature relationships in comparison to other people their age, and then they might be vulnerable to being taken advantage of socially. So there may be also social skills training, where they might need help seeking out and finding social opportunities that are appropriate and really meaningful for them. But with the right support, we can help them achieve these goals. On the other end, you know, when we think about people who are more severely or profoundly impacted by their disability, these are people who may have a lot more difficulty with language and with communication. They may not speak at all. They may be people who need supervision 24/7 and who need a lot of support in pretty much every area of living. However, with the right support, and if we can identify that this is how much support they need, we can give them that support so that they can have meaningful lives. A couple other comments just about like prevalence and causes, risk factors of intellectual disability. So about, our data is not great here, but about 3% of the population in Canada is thought to have an intellectual disability. As I said, it's more common, the majority of diagnoses are in that mild range, and it's more common in males. In respect to Indigenous communities specifically, we really don't have good data. So Stats Canada suggests that overall, there are probably higher rates of developmental disability in Indigenous populations. However, there are a lot of issues with that data collection. So often that data only flags people who have more severe levels of disability, and it misses people who are higher functioning. It also, there's just a general issue of underdiagnosis in Indigenous communities because of lack of access to resources and service inequities and distrust in services. And so we need to, be mindful of these things when we think about this data. There's also kind of limited general epidemiological research about population rates of intellectual disability in different Indigenous communities. We just don't do a lot of this research, again, because of inequities in the way that we do our research. And there are some good estimates that come from Australian studies that suggest intellectual disability might be about 1.5 to 3% more likely to occur in Indigenous communities. So there's probably a higher rate in Indigenous communities. And there's a lot of reasons probably for this. So when we think about the cause of intellectual disability, there's not like any one known cause. It's not like there's one gene and that gene causes autism. You inherit it, and you get intellectual disability. Instead, there's a lot of different genetic and physiological factors that either on their own or in combination can cause intellectual disability or put someone at risk for intellectual disability. And specifically, some of these things might be particular risk factors in Indigenous communities. So when we think about how illness and infection or seizure disorders, metabolic syndromes, maternal disease, some of these things, when they're not treated properly, we can't get adequate access to the right healthcare and monitoring, they put people at higher risk. And we know that there are service inequities in Indigenous communities, just general difficulties with accessing healthcare. Likewise, there is a history of Indigenous lands being taken from Indigenous people and being used for purposes that result in higher levels of toxins in the land and in the water that can also put people at risk for developing intellectual disability. So it's important that people be empowered with this knowledge of the risk factors that are there, and so that we can continue to make adjustments at a system level to help protect Indigenous individuals. Okay, let's talk about autism spectrum disorder. And the way we think about ASD now is kind of two categories of characteristic traits. So there's these social communication traits, and then there's also these restricted and repetitive behaviors, activities, or interests. We call them RRBs. And we look for traits in both of these areas, and that's what's characteristic of autism. But within these two areas of traits, there's a lot of variability in what autism can look like, which is kind of why we call it a spectrum disorder, because there's so much difference in how each person might present. So when we're thinking about the social communication piece, we need to see challenges or differences in all three of these areas. So the nonverbal communication is the first. That's things like eye contact, body language, facial expression, gesturing, tone of voice, rate of speech. And in particular, this is important for clinicians when they're working in Indigenous communities to understand what's socially normative of that particular Indigenous community. How do people in this community communicate? Because we want to make sure that we're not attributing differences to something diagnostic when really it's just cultural. So we need to be very careful here. We also look for differences in social emotional reciprocity. So this is differences in how people with autism might greet others, how they approach people socially, how they make social interactions, engage in the back and forth of communication and play, how they share interests, their ability to understand the emotions and affect of other people. And then also interpersonal relationships. So we see differences in how people with autism build relationships, what types of relationships they prefer. There might be differences in how they make friends, what type of friends they like, in their ability to understand the nature of relationships, how interested they might be in other people or appear to be in other people. So we see differences there as well. On the other side, these restrictive and repetitive behaviors, we look for evidence at least in two of these areas. So the first being repetitive behaviors. So that's like motor movements, whole body rocking, hand flapping, things like that. You might see repetitive use of objects like lining things up, organizing things. You might see repetitive speech, like echoing back or using repetitive phrases that they've heard somewhere. We might also see adherence to routines and rituals. So that could look like difficulty with transitions and change, rigid thinking patterns, being like very adherent to rules and following the rules, having certain rituals, wanting everything to be the same, like having the same morning routine, having the same breakfast, having the same route to school, things like that. We also see third is restricted and fixated interests. So often people with autism might have very specific and perseverative interests in topics, intense interests in things like trains or dinosaurs or space. And often this can be a great strength of people with autism that, you know, they can really learn and soak up a lot of information about specific topics. And we also can often see there's preoccupation with maybe unusual objects, things that kids maybe typically wouldn't play with. So being really interested in example in locks and how the mechanism of a lock works. Or instead of playing with the train creatively, you're more interested in how the wheel function of the train works. And then we can also see in autism hyper and hyposensory sensitivity. So that's over and under sensitivity to different sensory stimuli, like being very sensitive to certain touches or textures, being sensitive to certain sounds that no one else seems to be bothered by, seeking out intense smells. Like sometimes we have kids who will smear feces because the sensory stimulation is pleasing to them. Or we have kids also who will often take off all their clothes because the texture of the clothes is too overstimulating for them. So we see these kind of differences in how sensitive they are. And when we can identify these, we can then modify the environment to help people with autism function more effectively, to make the environment more accommodated to what they need. So I'm going to actually just pull up a little video. We won't watch the whole video, but we'll watch a little bit of it just to hear from the autism perspective itself, what it's like.
Autism is really hard to explain for me because I've never really experienced being a normal person, because I did that in quotes because, well, let's face it here, there really is no such thing as normal.
It can be a lot of different things.
It's a spectrum. Not everyone has every single symptom.
You can tell from someone's face if they have autism.
Autism is how someone's brain is wired.
Like, it's just part of your perception of the world.
Well, there's too much people standing around talking, too much noises. Just feels like uncomfortable.
It's lights and sounds that usually do it for me. Like, it's like the entire world is pressuring you and crunching onto you, and there's not really much you can do about it except just to get out of there.
I don't go to movie theaters. I've never been to a concert. I feel like I'm missing out on a lot of stuff.
I remember very early on, watching someone scratching at the carpet. The feeling sticks when it's really awful, and it's just
Some people with autism have a hard time knowing when someone's happy or sad or angry or frustrated.
I wish socializing were easier, definitely. Because there are so many times when I'm with other people who seem to have a natural flow of conversation that they all get, and it almost seems like they have a psychic link with each other at some point that I am locked out of.
If someone with autism is a quiet kid in a corner or something like that, it's usually because he's questioning himself. So if you see someone sitting alone or something like that, feel free to go and talk to him. It could help them out a ton. Trust me, I know.
All right. Hopefully you can all see my presentation again here. Okay, just a couple other considerations about autism. So one thing is you might come across terms like Asperger's, PDD-NOS, autistic disorder, child disintegrative disorder. So we used to kind of categorize people in all these different terms. And then we learned that psychologists are very good at identifying if someone has autism, but not so very good at identifying which of these categories they fall into. So they weren't very useful. So the current terminology is now we just use one title, autism spectrum disorder. But sometimes people still like to use particularly the term Asperger's. There's a bit of a sense of community that comes with that term. So you might hear people use that. And when we talk about age of diagnosis, so often symptoms of autism can be apparent as early as 18 months old. We can start to see signs pretty early, and we can start to monitor those signs from an early age. So if you have questions, you have thoughts from an early age, you can start seeing a doctor or a nurse practitioner to monitor the progress. We can reliably diagnose kind of as early as 2 years old. However, a lot of diagnoses don't happen until much later. So people who are more mildly impacted by their symptoms, it may not become as apparent until they are a bit older and until the demands of life and socialization are greater. Saying that, the earlier we diagnose usually means better outcomes because we can help to accommodate things earlier, and that supports people as they develop later in life. The prevalence of autism is about 1 in 54 people. It's always kind of going up. And that's just as we kind of, I think, get better at identifying ASD. There may be also some cause changes. Likely, rates of autism are about similar in Indigenous populations, but we don't, again, really have good data on that. And again, we need to be, as I've said, very careful about diagnosing autism in Indigenous populations, because the diagnosis is really based on differences that the individual is showing from socially normative behavior. But then we also have to keep in mind what is culturally social normative behavior and how it compares to that. So if someone doesn't have that perspective and lens, it can really impact the ability to make a fair and appropriate diagnosis. Etiology of autism, the causes of autism are genetic. And that doesn't necessarily mean that it's as simple as a parent has a gene and they pass it to their kid and then the kid has autism too. Sometimes that happens, but more often it's a complex genetic picture where there's kind of a combination of different genetic changes from both parents. And often also there are new changes that happen in the child's genetic structure that neither parent has that causes autism. And this is just part of like genetic reproduction process. Importantly, autism is not caused by vaccines. It's also not caused by frigid mothers. That was kind of like a story once upon a time, and that is certainly not the case. And it is certainly not caused by vaccines. There was a study done in the 1990s where somebody had drawn a link between autism and the MMR vaccine. And as it turns out, no one was able to replicate that research. And eventually people started to ask questions. And it turned out that the researcher who had initially found this link had a conflict of interest, had been biased because he was representing clients of a vaccine company who were suing a vaccine company, and they wanted to show this link. And so the data was actually collected in very inappropriate ways and very biased ways. So it was determined that it was not good science and the link was not accurate. So just something to keep in mind, that there's no evidence to support autism being caused by vaccines. Okay, let's talk about FASD, fetal alcohol spectrum disorder. So FASD is really an umbrella term because, again, like autism, the way that different individuals with FASD can present will look very different depending on how they've been impacted. But in general, it refers to the range of physical, medical, behavioral, and cognitive differences that can result from exposure to prenatal alcohol. So we call that PAE, prenatal alcohol exposure. And there are a couple specific diagnostic features that we look for. So first are facial features. And there's a lot of facial features that can be associated with FASD, but there are 3 in particular that are so specific to prenatal alcohol exposure that they're used diagnostically. So the first is the small palpebral fissure, which is the space between the inner and the outer corner of your eye. It tends to be smaller. A smooth philtrum, so that's the space of the upper lip is smoother, though you don't get that same indentation. And then the thin upper lip is also something that we look for. The second thing that we take a look for is central nervous system impairment. And that refers to a really broad range of traits, including cognition, motor skills, language, academic achievement, memory, attention, executive functioning, affect regulation, adaptive behavior, neuroanatomy, and neurophysiology. So there's all of these things that we can look at, which really gives you the sense of how different, depending on which of those areas are impacted, how different each person with FASD will be. And then, of course, the third diagnostic feature is maternal alcohol exposure. And we can make the diagnosis without confirmation, but this always needs to be at least strongly suspected. So as I've said, there's lots of variability from case to case. However, there are some really common things that we tend to see in most people who have FASD. And the first is an uneven profile of cognitive abilities. So while we talked about intellectual disability, where we tend to see a pretty low pattern of abilities across all areas of ability, with FASD, it's really common that we might see someone who's got really, really strong, like above average abilities in one area, and then very low, like bottom 2 percentile abilities in another area. So there's quite this scattered profile. Now, people with FASD may also have intellectual disability. So sometimes they will, but sometimes they won't. And sometimes we really see this scattered profile either way. Difficulties with affect regulation is another challenge. So being able to control emotions, emotional responses to stress. People with FASD often can kind of be triggered really quick and go from 0 to 100 in their emotion very fast, but that has a lot to do with how alcohol impacts the development of brain structures that are important for emotional functioning and managing stress and affect regulation. Likewise, it's also very common that people with FASD have difficulties with some areas of executive functioning. So that refers to like higher order cognitive skills that are required for problem solving, goal-directed behavior, things like self-direction, initiation, organization, working memory, flexibility, cognitive flexibility, that is. And this is really because, again, the effects of prenatal alcohol on the developing brain really impact the frontal lobe, which is where the area of the brain that controls these abilities. So just a couple things to think about for FASD diagnosis. Really, this diagnosis should be provided by, an assessment should be provided by a multidisciplinary team where you can have different professionals who can assess medical pieces, cognitive pieces, functional abilities, who can confirm the alcohol exposure. And of course, this is a big challenge, I think, for Indigenous communities where you don't have access to these like mega teams of clinicians who can do all of this. So sometimes it's in the prerogative of clinicians to really think about how they can be creative to make sure that they do a full assessment, but in a way that's accessible to Indigenous communities. And as I said, there are different diagnostic designations that can be made. So we make the diagnosis of FASD with sentinel features. If we see those 3 facial features, if there's enough evidence of those, and if we see impairment in at least 3 of those central nervous system or neurodevelopmental domains I talked about, in those cases, we can make the diagnosis even if prenatal alcohol exposure is not confirmed. If it's just suspected, but we can't confirm it, we can still make the diagnosis because those facial features are so characteristic of prenatal alcohol exposure. We don't have those facial features, then we can make the diagnosis of FASD without sentinel features when we are able to confirm prenatal alcohol exposure. So in this case, where there are no facial features or not the 3, we need all 3. So if we don't have all 3, we can only make the diagnosis if we have that confirmation of alcohol exposure. And then there is a third category. It's not a diagnosis, it's just a designation that's recommended where we can identify someone as at risk for neurodevelopmental disorder and FASD associated with prenatal alcohol exposure if we've confirmed that there is alcohol exposure, but we haven't been able to confirm evidence of the facial features or neurodevelopmental impairment. And usually in this case, we have to have a good reason to think about, well, why didn't this show up? And so this is something, again, relevant to Indigenous communities where perhaps there's a lot of barriers to being able to do all of the assessment and the testing, or the testing is not appropriate for an Indigenous individual. So the norms are going to be off, and we might be able to make a good case that way. All right. I also want to just talk a little bit about the benefits of an FASD diagnosis, because often, this is quite a stigmatizing diagnosis. It can be quite difficult, especially for mothers, to support the diagnosis, because it often feels like a lot of blame is being placed on the mother. And so it can be helpful to think about some of the benefits that also come with the diagnosis, including access to disability income, so ODSP in Ontario, Also, it's possible that through the diagnostic process, you might be diagnosed with an intellectual disability or become eligible for DSO, developmental service supports. And those are supports that can help with other secondary disabilities like housing supports, legal supports, employment supports. And the diagnosis can also be beneficial for self-understanding. So a lot of the time, people with FASD live a lot of their life hearing, you're a bad kid, you can't do things right, you're always getting in trouble. And they can internalize that feeling, I'm a bad person. And the FASD diagnosis can help a lot of people understand that it's not them that's bad. There is something about how their brain functions that requires different environment and can make everyday living challenging. And so it's, it helps understand identity. I'm going to show another video, again, just a clip from Morgan Fawcett, is incredibly well-spoken young man living with FASD who does a much better job at talking about the experience of having FASD and diagnosis.
I'm a child of the Kagwantan and a grandchild of the Dukdantan, and I'm 19 years old. I'm an alcoholic. My mother drank 90 to 100 days during pregnancy, so I live with many of my own FASDs. I have both physical and neurological disabilities. I have spina bifida occulta, scoliosis, a mucus cleft palate. My eyes focus at 2 separate times. I have other sensory integration problems. I have deformed hips. I have many learning disabilities. I have short-term memory. I have the cognitive skills of a 4-year-old. I have the overall brain development of an 11-year-old. It's not easy living with my FASDs, not just for me, but for my grandparents, because they're with me every step of the way. They're my external brain. They work with me, and they help me be successful. I had no clue that I was struggling because parts of my brain didn't develop. I was struggling because my body didn't develop right. So I simply felt stupid. But the more I read, the more I realized I wasn't stupid. The more I read, the more I understood why I did or didn't think in certain ways, why I did or didn't understand certain subjects. And that was huge. It was like 1,000 pounds was lifted off my shoulders. I can't tell you how many times people said to me, well, I don't want to label my child. We don't want to have a diagnosis because that's just going to be saying that they have a problem. Well, denial doesn't help, but acceptance and knowing that you have a disability, know where you lie, not only brings relief, but it also gives you a base of where you need help.
Okay. Such a powerful message from him, and much more meaningful to hear that from somebody affected than just me. So a little bit about prevalence and causes of FASD. So approximately 2 to 3% of Canadians have FASD. Probably this is underreported because of the stigma. And in the Indigenous community, FASD is reported about a 4% rate. So there's really not a difference between the general Canadian population and the Indigenous communities in Canada. And I think there's a very big misconception that FASD is associated with a specific ethnocultural background, that people with Indigenous community are more likely to have FASD. In fact, FASD comes from diverse backgrounds. And this is particularly problematic because it impacts how we do research. And there's really a strong focus of understanding FASD in Indigenous communities through research, but not other developmental diagnoses that are also prevalent. And the other impact is that when we triage kids for assessment, there's often a bias in clinician minds that, oh, they're Indigenous, so let's put them through for an FASD assessment, instead of thinking about, maybe actually we should be looking at autism or a different diagnosis here. And so this is, again, important information to have so that we can advocate for our Indigenous clients and to make sure that they get adequate and appropriate health care. Of course, the cause of FASD is prenatal alcohol exposure, drinking during pregnancy, and presentation of FASD can be very different depending on the amount of alcohol that's consumed when and how it's consumed, any pre-existing genetic factors that might interact with that alcohol, as well as environmental interactions across the lifespan that might interact with specific vulnerabilities. So it's quite a complicated picture that we're still learning a lot about. And because of that, really, the most safest recommendation is that no alcohol should be consumed during pregnancy. As far as we know, there's no safe amount of alcohol to drink. And that's not to say if someone has been drinking and then they find out they're pregnant, we don't want that to be discouraging. If at that point it's about kind of helping people develop strategies so that they can discontinue drinking once they know that they're pregnant.
Layla, I have a question for you.
Yeah.
It's not my question, but Marcia has a question. So that wonderful video that you just showed, is it possible to share the link for that?
Absolutely. How do I do that? I can just put that in the chat to everyone, right?
That would be great, yeah.
Yes, okay, I will do that at the end of this. Once I'm done kind of presenting, I'll put that in, I'll put both links in the chat for anyone who's interested.
Fantastic, thank you.
Yeah, we are almost finished too, so we can have some more questions as well. Just a couple really quick comments. I'm not going to go through all of these because we could be here forever. But other diagnoses for consideration, other things that either are categorized as developmental diagnoses or that often are comorbid with other developmental diagnoses. There are a number of neurodevelopmental disorders, so you might be quite familiar with, like Down syndrome, learning disorders, attention deficit hyperactivity disorder. There's also a number of communication disorders that impact how people are able to speak and communicate. So language disorder, speech sound disorder, fluency, that's like stuttering, social communication disorders. And then there's also motor disorders that impact how people are able to perform physical and motor skills in their daily life. So these are all things, diagnoses that can be taken into consideration. And usually when we're seeing someone for an assessment, we consider all of these differential diagnoses to figure out which one fits best so that we best know how to support the individual. Another quick note, especially for educators in the room, there is a designation. It's not a diagnosis, but it's a designation called borderline intellectual functioning. So we talked about how intellectual disability is given to people who are in that bottom 2%. But we also know that, there's kind of these people in this gray space, this borderline range, the 2nd to 9th percentile, that are still going to cause difficulties for learning and for everyday functioning. And so in these cases, often students can qualify for a Ministry of Education designation of mild intellectual disability, and that will increase their access to supports within school. So that's just something important to keep in mind for these kids who kind of fall in this gray space, and we still want to be able to support them. There's also a number of medical diagnoses that are associated with developmental disability and intellectual disability that you may have come across at different times in your life. So really quickly, just a bit about supports and resources. Of course, supports and resources are going to be really community dependent, and there's going to be different things that are available to different communities. Some government programs that are available to everybody, like Jordan's principle, of course, is something where funding can be accessed to help with individual supports to build community support programs. Developmental Services Ontario provides support for people who are older than 18. So things like extra funding, like money that you can purchase, even telehealth supports with, purchase technology with, housing support, support workers. So depending again on the community you're in, they'll be able to access more or less of the resources through DSO. There's the Ontario Aboriginal Head Start Association for early intervention programs. There's the OAP and childhood autism budgets for people who are under 18 and who have an autism diagnosis. They can access this funding to help them purchase services and technology, even again, telehealth services if you don't have in-person services that you can access easily. And in general, technology can be really helpful for kids in their learning and their everyday functioning. So things to think about. At Surrey Place, we have 2 different services that support Indigenous communities. So our Surrey Place mobile clinical team is an interprofessional team, psychology, social work, OT, and BT, and we provide telehealth and in-person services. So we do travel, and our services are purchased through fee-for-service contracts by individual communities so that we can individualize the community needs. And we work in Northwestern Ontario. And so if you have any questions about that, you're welcome to contact me and I can put you in touch with the right person. We also have our MMW video conferencing program, and this is all done by video conferencing. It's for people who are over the age of 18 and who are clients of DSO, or for clients who you suspect might be eligible for DSO. We can do those eligibility assessments and get them more access to a range of supports, including psychologists, behavior therapists, OT, speech and language, psychiatry, group services. And there's more information. I'll share that link as well in the chat at the end here. And finally, just a couple resources. These can help you access like handouts, toolkits. So the H-Card website and the Developmental Disabilities Primary Care Program, they have like screening tools if you think or suspect that someone might have a disability, if you want to know more about the assessment process, if you want to help people navigate the healthcare system and advocate for them in their healthcare system, there's really helpful resources there. And Shikabe Makwa, which is kind of the Indigenous training arm of CAMH, are a wonderful team. And specifically, they have a number of great trainings, but specifically with them, I've worked, and Chiefs of Ontario as well has worked together on creating their training program, A Beautiful Difference, which is a primer. So it goes more in depth about a lot of the stuff that we've talked today. And that gets offered at different times of the year. All right. I think that's it. I'm done talking. Thank you for listening. Hopefully you haven't all fallen asleep or aren't all totally confused and overwhelmed, probably a little bit. I will stop sharing my screen and I will pop some things in the chat while we see if there are any questions. Yeah, sure.
Okay.
I'd be happy to share those slides. Sorry, I just saw that come up. I would be happy to share those slides so that there are, I don't know, the best way to do that maybe is to send them to you, Patrick? And you
Yes, if you email to me, we can send that out to the participants. That's a good idea. And thank you so much. That was a ton of information. And if you have, yeah, it's okay. So my question was answered too. If you have any questions, you can type them in right now. You can also put your hand up and I can unmute you if you're brave enough to speak. But yeah, we'll take a few minutes for Q&As.
So in the chat, I put the 2 video links, and then there is the MMW program link. Yeah, so that Morgan Fawcett video is one of those first 2 links that I just popped. Oh, I'm just sending them to Patrick. Well, that's not helpful. Send them to everyone. Let's try that again. Okay. Here we go. That's the Surrey Place MMW one. Then, nope, that's not working. Okay. Here is, this is the autism video. And the one, Morgan Fawcett, is such an incredible video. He's often, I think, speaks at different conferences as well and workshops. There's that video.
Okay, here's a question for you. Do you have any suggestions with helping to get an FASD diagnosis for children and how to speak to parents?
Yes. So in terms of I guess if the question is about accessing how to access the FASD diagnosis clinics, that can be really tricky. I think it depends a little bit on what community you're in and what you have access to. I know like there is, at least in the communities that I work in, like there's a big team through Thunder Bay, through the Sioux Lookout Health Authority, at Firefly. So there's some teams that work in Northern Ontario to do the diagnosis. We also take referrals for clients through Surrey Place sometimes. In terms of like encouraging families to consider how it might be beneficial, I think it's really an ongoing process of building rapport and helping them to understand, like even just sharing this video might be something that's interesting to talk about, the challenges the students facing and the benefits that might come with the diagnosis, the access to supports, to being able to have better understanding. One thing I think that happens is when kids are in a smaller community, that can really understand them and support them, they do okay, right? Like if they're in a school where everyone's been familiar with them in kindergarten through to grade 8 or 6, whatever, it's easy for the school to make accommodations. But when they transition, especially to high school, and change schools and often even have to change communities, that's when challenges really can start to happen, because the community and the people supporting them don't understand them as well. So when they can travel to a new school with a designation, then the school knows already the supports that they need. And in fact, when that's designated on the IEP, they are entitled to those supports legally. And so there's that can often be a helpful thing when you think about it from the perspective of supporting the child and the help that they need. And there's some other really great videos actually on the Surrey Place YouTube. Let me see if I can pull it up here in a second. Different kind of informational videos and workshops that might be helpful.
Great question, Marcia.
I'm just going to put the link for the Surrey Place YouTube, and you can kind of peruse those videos and see if anything is helpful. There are some specifically on FASD education and like the experience.
Okay, thank you. So we have a couple more minutes. So if there's any other questions, feel free to ask in the chat or put your hand up. So I do have a question while we're waiting and see if there's any others. So you mentioned early on in the presentation that in terms of intellectual disability, males were at a higher risk. What's the connection there? Can you elaborate on that?
Absolutely, yeah. So it's largely thought to be genetic. There are some other factors that play a role there, but essentially what happens is for males, they have an X and a Y chromosome, right? And so if there is a genetic change on the X chromosome, there's no second X chromosome to help kind of mitigate the effect of that genetic change. Whereas in women, because they have 2 X chromosomes, if there's just an issue with the 1 X chromosome, then often the genes on the other, if they're not impacted, can kind of help dampen the effects of that gene or even prevent it from taking effect. And so because of that, that's part of the reason why we think that it just tends to be more common in autism, because there's specific X-linked genes that are related to intellectual disability and intellectual functioning.
Good. Thank you so much. Okay, Marcia saying thank you so much.
Thank you.
Great session.
Great,
Okay.
Thank you.
So last chance for questions.
I've left everyone stunned and confused.
Yeah. Well, I think you provided with lots of good links there and your contact information. So I'm sure if people have any questions after the session, they can reach out to you. They can also reach out to us here at Chiefs of Ontario, and we can facilitate some information exchange. But yeah, we're really thankful to have you here today, Leila. And we thank you so much for sharing your expertise and knowledge and for all the good work that you're doing out in the Northwest communities also.
Thank you. Thank you. Oh, I see.
There's a question. Okay. Do you have any suggestions for books or further reading from Amanda?
Ooh, that's a great question. I think a lot of the books that I have are not the most reader friendly or approachable, but you know what I'll do is I do have a resource list somewhere on my computer. So when I send the slides to Chiefs of Ontario, I'll send a little bit of a list of that too for people who might be interested in reading a bit more, a couple journal articles and a book or two. Yeah.
Okay, thank you. Michael says outstanding presentation.
Thank you.
Great. Yeah, everybody say thank you. And yeah, awesome. I couldn't agree more. Okay, so thank you so much, and thank you for the ones that took the lunch out of their day to join us here today. It's fantastic. So have a great day, and we'll see you in future webinars.
Okay.
Bye.